Hi. The microphone is on. I don't actually know how to turn it up. Is that better? Okay. Okay. So we have Dr. Moore here this afternoon. I mean, he's Dr. Williams' husband and also an endocrinologist. And he's going to talk to us today about hypertension. So I'll just press, oh, it's already being recorded. Okay, perfect. So when I pressed this the last time, it shut down, but we'll see if it works better this second time.
All right, we're going to do this. Great. And this talk was co-written with Bob Badgett from the Departments of Preventive and Internal Medicine at KU, and then Matt Tebow, who I work with at the Kansas Business Group on Health. Let's see if we can get these to advance. There it is. So the first disclosure I always make with you guys is to beware what you believe what I say, because I don't really practice anymore, and it's always risky to take advice from someone who's not actively practicing. I left academic practice about 6 years ago to start a consulting company, and I work with the businesses you see on the screen, along with a couple others. So if it sounds like I'm judging the way people are practicing, like throw a rock at me or something, because I know practicing is hard. That's why I don't do it anymore. Yeah. So by the time we're done here, I'm kind of combining hypertension and hyperlipidemia into one talk because they're so intimately related, as you'll see. By the time we're done, I hope that you can understand why everybody says you should start using the pooled cohort risk assessment to identify your high-risk patients. And I hope that you start to move away from the idea that you are a heroic figure that sits in a room like the Wizard of Oz that people come in and be healed by, because that's never really been a functional model of medicine, at least post-tuberculosis. And with the patients we see anymore, it's really not. Furthermore, I hope you can identify some treatment cut points for lifestyle modification and drug initiation for hypertension. I hope you understand why it is that patients don't adhere to medications. The short answer is money, right? I hope I can identify some community resources that help you out, and I hope you can at least outline roughly some team-based strategies. So first things first, you guys are really, really lucky in that you have extremely life-saving therapy that you offer patients in the form of childhood immunizations, right? But for those of us whose practices are mostly limited to adults, hypertension is where it's at, right? So if you look at the single most effective life-saving therapies in all of medicine, they are, as you see here, hypertension treatment, hyperlipidemia treatment, appropriate use of aspirin, and some minor contribution of pneumococcal vaccination. Smoking cessation would be the best one, except even the best clinics are so bad at it that we really don't make a huge dent, right? Because if you want to interpret this figure, the way this works is that the right side of each one of these is a very high functioning clinic. Consider it like the natural standard. The left side is usual practice. So down here, you see that nationwide, most clinicians control about half of their hypertensives. But if we were to get everybody up to the level of Kaiser Northern California, where the control rate's about 90%, we would see a linear decrease in the number of patients who have heart disease every year. About for every 10% increase in control, we'd see about 14,000 fewer deaths. Kaiser Northern California actually has more patients dying of cancer than they have dying of vascular disease, because they're so outrageously effective at treating hypertension. And hyperlipidemia is kind of right there with it. So just remember that. The two things that will save the most lives over your career, as boring as they are, and I know they're boring, is controlling people's blood pressures and controlling their lipids, okay? All right, in spite of all that knowledge, we know that hypertension is fairly poorly controlled in this country. We've seen this sort of gentle increase over the last 20 years or so that's now starting to fall off. And if you look at people who are actually taking antihypertensives, the numbers are a little bit better. You see about this 15-point increase in overall rates of control. But in general, we tell people to remember the rule of halves in hypertension care. Only about half of people who have hypertension are diagnosed, and only about half the people who are diagnosed are controlled, right? Okay. And in spite of the knowledge that statins are maybe the second most effective life-prolonging therapy in all of adult medicine, too few people get them. So I'm showing you data from a couple of years ago from HEDIS. But you see that amongst commercial payers, only about 2/3 of patients who need a statin get one. It's better on the public insurance side. It's maybe 3/4 in the Medicare population, but still, there are a lot of people who deserve a statin who are not getting one. So why aren't they better treated? Why aren't we doing a better job of this? And so had you asked me when I was in practice and in the process of rapidly burning out of medicine, I would have said it's because patients are not adherent, right? They don't do what I say, which is true to some extent. But by the end of this talk, I hope I can convince you that there are really two factors that go into why we don't better control hypertension and hyperlipidemia in this country. One is therapeutic inertia. And that's just the idea that whatever's happening now is likely to happen tomorrow, right? So changes are hard to make, and for reasons that we'll go through. The second is suboptimal adherence, and we'll talk about why that is. So if we were to get rid of therapeutic inertia to where the right treatment happened at the bedside without affecting adherence, we probably wouldn't make a huge difference, right? And if we were to find every patient out there that needed a drug, if we were to get every patient who was prescribed a drug to take it, that alone wouldn't make a huge difference. But by addressing both of these, we would see some difference in outcomes. So therapeutic inertia, you guys have all experienced. It affects 80 to 85% of all visits relating to blood pressures. It's the failure of a health provider to initiate or intensify therapy when the situation calls for it, right? And it goes both directions. So I'm sure there's someone watching or in this room who has seen an 80-year-old on glyburide whose blood sugars were well controlled, and you said, well, don't want to rock the boat, right? In spite of the fact that glyburide kills old people, right? It's just hard to make changes. And so about 80% of the time, or maybe even a little more, when we see a hypertensive patient, therapeutic inertia affects the visit. Either we fail to advance the therapy, fail to initiate therapy, or fail to de-escalate therapy when it's indicated. So why is it, and I'll pick on the people in the room and I'll let the people remotely listen in. Why do you think therapeutic inertia happens? Why is it that we don't always advance therapy when it's indicated?
Fear of overtreatment.
Fear of overtreatment, right. That's a great one. I have killed a few people in my career, and I killed all of them with insulin, right? Every single one of them. So that is a legitimate fear. Somebody else said something.
I was basically the same thing. Also, like patients, I don't know, like patients have therapeutic inertia. They're like, why have I been on that before? I don't want to start a new medicine, or I don't want to stop this. I've always taken it.
Yeah. So on the physician side, you don't want to be the pill pusher, right? You don't get a reputation as someone who's always writing a new prescription, right? Yeah. Agreed. Would you say that your electronic health record makes it super easy just to add? So say someone's on 10 milligrams of lisinopril and you want them to start taking 20. Does your EMR make it super easy just to make that change happen? If it's like every other EMR in the world, the answer is probably no, right? It's very hard. What else? Any other big causes?
Just like lack of trust of the measurements too. You're like, for some reason I don't.
Okay, yeah. That's a good one. Lack of trust of the accuracy of the blood pressure measurement. I think I heard Jared say that you're just too busy, right? So if someone's in complaining of back pain and like bloody stools, it's hard to get to their blood pressure, right? Well, so there are a few things that you guys have hit a lot of them. There are a few things in the literature that relate to this. One is that doctors are, I think we're all inherently optimistic. We're not as optimistic as the public health folks, I've learned, but we're pretty optimistic. So we say, well, her blood pressure is usually okay, and here it is high. So do I act on the usually okay number, or do I act on today's number, right? One is that we say, okay, last time her blood pressure was 160, now it's 146. what point of the trajectory is she on, right? So if I check her in a week, will it be 139 then? So we sort of use this soft reason of like almost there, right, not to advance therapy. The biggest one I would say is that we lack organizational training in treating the target. We're going to spend a lot of time on that. There's clinical uncertainty, which you guys touched on. You don't want to harm patients. And there are competing demands, like somebody said. Remember, even 10 years ago, the mean number of problems encountered or addressed at any primary care visit was 3, and that's only gone up since then, right? And so if 2 of those problems are symptomatic, it's hard to get the patient to focus on the asymptomatic one. There's and in that vein, poor patient enthusiasm for treating asymptomatic conditions and inconvenience, as you guys said. So my favorite illustration of this is from this study that you guys may have reviewed in Journal Club or something. It's from a couple of years ago in the New England Journal. What they did was they cluster randomized barbershops to either have a pharmacist on site who would measure the blood pressure of patients and advance their therapy according to a very strict algorithm, or they had people getting usual care from their primary care doc. And what they found, and so at the end of the study, everybody had seen their primary care docs exactly the same number of times. There was no reduction in primary care from this. The patients were just seeing this pharmacist in their barbershop as well. And what they found at the end of the study was that the people who were seeing the pharmacist had much better blood pressure control at the end of the study. And it wasn't anything magical that the pharmacist was doing. She had an algorithm that said, if the blood pressure is 140 or above, come hell or high water, that patient is getting a medication increase, right? The end. It's not even the pharmacist's choice. The algorithm says to do this, therefore we do it. So at the end of this study, the people seeing the the barbershop-based pharmacists were just on an additional medication compared to the people who are only seeing their primary care doc. That's it. They had eliminated therapeutic inertia, right? The pharmacist didn't have a choice. If the algorithm said do it, they did it. So the study, for some various reasons, is only a moderate demonstration of the effectiveness of pharmacists. They did some other squirrely things, but it's very effective at showing therapeutic inertia's effect, when you at least especially when you take it away. And so this applies to your patients in that, remember, in hypertension, we've classically talked about the rule of halves. Only about half of people are controlled. Only about half of the uncontrolled people are treated. So it's not just a matter of putting people on advancing doses of medications. It's a matter of recognizing it, and it's a matter of screening, right? So in the statin world, we see something kind of similar, right? So if you look at everyone surveyed who should be on a statin who is not, the majority of them say that they've simply never been offered one. Now, they say that. It's entirely possible that they were. But if they were offered one, they were offered one in some way that didn't quite sink in, right? And of people who have reported a historic intolerance of statins, most of them say that they would try another one, right? So of people who've never been offered, 2/3 say they'd be willing to try. Of people who have had a historic intolerance of statins, about half of them will restart. Of that half, about 90% will still be taking it a year later, as long as you follow up with them. So that gets us through therapeutic inertia, right? That's our side of this problem. Adherence is the other half of this. So what do you guys think happens when you send in an e-prescription to the pharmacy? What is the likelihood that the patient ever picks up that prescription? I'm not talking about OxyContin here, right? I'm talking about the other stuff. So your prescription for hydrochlorothiazide, how likely is it that your patient will actually go pick that up? You guys are pretty close. Yeah, so about a quarter of all prescriptions are never filled. If you look at everything, that includes narcotics and whatnot. So it's bound to be a little bit less, or that number is bound to be greater amongst hypertensive medications. How many patients are still taking that drug a year later? Assuming that you're still prescribing it. Yeah, 50%. About half of people are still taking the drug a year later, in spite of what they say, right? So the reasons that people don't take medications are mostly related to one, mostly costs, but two, also convenience, right? So to affect the cost side of this, we know from pretty good RCTs that if you never, ever write dispenses written, people are much more likely to take their medications, right? And in Kansas, it's actually a rule that if it doesn't say dispenses written and there's a generic available, the pharmacist has to dispense the generic, okay? So don't write dispenses written unless you have an astonishingly good reason to do it. We also know that high deductible plans are associated with much lower rates of filling prescriptions, and we know that higher copays are associated. So on any given day, only about 2/3 of your patients are taking their drugs. And again, about 1 year after initiation, only about half of people who you've prescribed the drug to are still taking it. With statins, at 2 years without sort of steady work, it's about 1/3. So here's my somewhat unfounded opinion, although I hope I'm making a case for it. If you guys maybe aren't like the internal medicine residents who like to sit around and mentally masturbate over like LDL goals and blood pressure goals, but if you are, I want to if you are, it's okay, but I would say in clinic, the much more valuable or important decision is not, do we treat to an LDL of 70 or not, or do we treat to a blood pressure of 130 or not? The decision is, what system do we put in place to make sure people get to whatever goal it is that we're aiming for, okay? And this isn't a new idea. Remember, there are probably people on your faculty who practiced before there were insulin drips in the hospital, right? I don't think there are any in this room, surely. But remember, once upon a time, if you wrote an insulin drip in the hospital, that meant that you got called every hour with a blood sugar, with a nurse asking you what you wanted to do with it. And those hourly calls ended either when you stopped the insulin drip or when the universe underwent heat death, whichever one came first, right? It never stopped. And the outcomes were terrible. So eventually people at Yale figured out that we could just write an insulin drip protocol that let the nurses be in charge of it and let them do it, and the outcomes improved. The same thing happened with heparin, right? Once upon a time, if you ordered a heparin drip, you got called every hour with a PTT, and the nurse would ask you, would say, the PTT is 80, the drip is at this rate, what would you like to do? Is there anybody in the room that would know what to do with that? Because I wouldn't know. I wouldn't even know what to do with an insulin drip. But that's what happened. And so people bled to death all the time, right? Same thing with chemotherapy. So we've taken all this stuff and we've simply written protocols that allow other providers, other practitioners to help us with this work. And I would say things like hypertension and dyslipidemia should fall into that category. And important people agree with me, right? So now the AHA gives a category A rating to team-based care for adults with hypertension. And important family docs like Tom Bodenheimer say that if we don't embrace this strategy, primary care is dead, right? He says embracing this strategy is vital to the future of primary care in general. So think about who your team members are. They aren't just pharmacists and nurses and medical assistants and whatnot. They're also your front desk staff. They may even be patients in some instances. So let's go through a case. Normally, I would have you guys kind of huddle and argue about this, but we'll try to keep from infecting one another here. So let's assume that a 50-year-old guy comes in to you with no history of diabetes. All he wants to do is quit smoking, and he wants help with it. On his intake, his blood pressure is 152/94, which is confirmed on repeat measurement. So one of the ways that your team members can help you is by identifying high-risk patients. So is this guy high risk? We don't know. So I want to reorient the way you think about clinic, where you do all the documentation and you're considered the hero of the day or the villain if things don't go well. I want to reorient you to a model that looks like this. So imagine that you have 3 medical assistants, or at least 2.5, but let's say 3 medical assistants working under you, and simultaneously in 3 rooms, they're doing these 3 things. So in room 1, which is a patient you haven't seen yet, They're getting vital signs, setting some agenda, setting up equipment for any necessary exam, and addressing any gaps in the care that have been protocolized by the clinic. You are seeing the patient in room 2 while the medical assistant that's with that patient is documenting for you. And in room 3, which is a patient that you've already seen, the medical assistant is checking for the patient's understanding, ordering any tests, setting up referrals and future appointments. So all that stuff that you don't want to have to do. Meanwhile, you just kind of circle this and go from room to room, and your entire job is to pay attention to the gaps the medical assistant has alerted you to relationship build with the patient, do a good exam, and make treatment decisions. You don't document, you don't do any of this other junk that you get stuck doing now. So your medical assistant knows by your clinic protocol that since this guy is over age 40 and there's no lipid panel on his chart, that he needs to have his lipids checked, because it should happen every 5 years beyond the age of 40, right? Furthermore, she knows that all these barriers to lipid testing have mostly been eliminated. You don't need to fast for these. If your triglycerides are over 400, then you come back fasting to get them drawn. And if we already knew he had heart disease, or if we already knew he had an LDL over 190, or if he was diabetic, we wouldn't need to check them at all, right? He would just qualify for therapy. So she goes ahead and checks his lipids with a fingerstick device based on a clinic-wide protocol that you already have. And here are his results. So 56-year-old guy, no diabetes, smokes, blood pressure is that. And his cholesterol is like spectacular, right? Better than mine. Look at that HDL of 62. So what's this guy's risk? Does this guy qualify for a statin? Any thoughts? Yeah, you got to use a calculator, right? So there are lots and lots of them out there. What you see here is that they're all roughly equivalent. So the one that's kind of gained purchase in the culture of medicine is the ACC-AHA calculator that you see there. So we put his numbers into that calculator, and he comes back with an 11.3% 10-year ASCVD risk. What is the threshold traditionally that we use for primary prevention with statins? Do you remember? Yeah, so ACC says 7.5, USPSTF says 10%. So either way, he qualifies for therapy, right? In spite of the fact that this guy showed up at the clinic looking healthier than I am. I'm not on a statin, by the way. Hooray. That's true. So this is why you have to calculate people's risk, because if you just eyeball it, you're going to get it wrong, okay? So we know he needs a statin. We know he wants to quit smoking, but then we have this blood pressure that he showed up with that we have to deal with. So is this guy hypertensive or not at this point? With a single yet confirmed, and it's been measured twice in this visit, but it's been high both times, 152/94. Any thoughts? Okay, yeah. So historically, it takes 2 separate readings on separate visits to establish the diagnosis. Now, the ACC and AHA have moved toward out-of-office blood pressure monitoring as the gold standard. So you can still do that. If for some reason the patient just refuses to do this, then have him come back on another day and remeasure it. But the gold standard now is considered blood pressures that the patient obtains outside the office, okay? Because we know that ambulatory blood pressure measurements, which is the automated form, right? That's where you wear a device around and it checks these without you having to do anything. We know that those are the gold standard in terms of predicting risk. They are much better at predicting mortality than blood pressures you get inside the office. The trouble is they're almost impossible to get paid for. It's like pulling teeth to get Medicare to pay for these or any private insurance company. So what we've done through our organization is establish an agreement with all the fire departments and all the EMS stations in town that says that 24 hours a day, 7 days a week, 365 days a year, you can go to any fire or EMS station and get your blood pressure checked by someone who knows what he or she is doing and you can write it down. So we have a few thousand of these handouts with a wallet card to write blood pressures on floating around town. And we'd be happy to provide them for you guys, branded if you're interested. So if we can't get out of office blood pressures, at least 2 readings on at least 2 different occasions, averaged. But if that is even too much, then automated in-office blood pressures are now considered the gold standard for what you use in practice. So instead of having your MA or you listen for cough sounds, you put an automated cuff on the patient just like they use in the hospital. So in trials, these are similar to ambulatory blood pressure monitoring in terms of predicting risk. Why is that? It seems to be because it eliminates all bias, right? So remember, every blood pressure you ever check ought to end in 2, 4, 6, 8, or 0. We don't use odd numbers in blood pressures, right, when we do it ourselves. Because of operator anchoring, about 60% of traditional blood pressures end in 0, where if there were no bias involved, it would be about 20%, right? A fifth of the blood pressures. And we've shown, or another team has shown, that within another health system here in town, there's bias. Non-white patients are more likely to have a blood pressure ending in 0 than white patients are. So if there's any way for you to get automated blood pressure cuffs in your clinic, I would encourage you to do it, either now or when you're in clinic or when you're in your own practice. And so this isn't something I'm going to go through. I just want to reinforce to everybody that the method of blood pressure measurement drastically changes the results. So routine clinic blood pressures that are high tend to run about 15 to 30 millimeters above an automated clinic blood pressure, okay? So it also changes the goals that you aim for, as we'll talk about. All right, so the nice thing about using a calculator isn't only that it tells you who to treat, it also tells you how to treat them based on the results of good trial data, right? So we know that this guy, in spite of walking in as seemingly the healthiest guy in the world, qualifies for a moderate intensity statin, which are listed on the right side of your screen here. And he also, assuming that blood pressure holds up over time, qualifies for blood pressure management, probably with 2 different agents in a combination pill. If you're checking his blood pressure with an automated cuff or through home monitoring, his goal should probably be 130/80 based on the results of the SPRINT trial. If you're checking manual blood pressures in the clinic, 140/90 is probably reasonable, considering that's the HEDIS goal, and you know that a manual blood pressure is going to come back higher than an automated one on most occasions. Questions on that? Okay. All right, so 3 months later, office blood pressures are always 130/80 or so on a reasonable dose of hydrochlorothiazide and lisinopril. Today's visit, he's 143/93. So there's a major problem with that, right? There's a technique issue because your MA has used bad technique. The blood pressure should never end in an odd number. But regardless, the repeat measurement with allegedly good technique confirms that. What do? He's been good up until today. Today his blood pressure is high. Does anyone advance his therapy? Does anyone say, looks pretty good, let's check again next time? So I think sending him to collect home blood pressures is perfectly reasonable. But I think advancing his drugs is also perfectly reasonable. Because remember, therapeutic inertia is probably the single biggest reason that people are uncontrolled in this country. So we need to overcome therapeutic inertia. And so our staff can help us do that along with managing adherence, right? So before we advance this guy's drugs, we'd want to make sure he was taking them. You can use pharmacy records if you want to ask in the clinic. The only way to do it wrong is to say, do you take all your medications? Because patients want to please you. It's an inherent bias. If you say, do you take all your medications? 100% of the time, the answer will be yes, right? In spite of the fact that we know that a year from the diagnosis, only 50% of them are actually taking them. So don't ever ask someone if they're taking all their medications. Instead, soften your language to try to get around that desirability bias. So there's a good trial showing that when people, instead of asking, do you take all your medications, when instead the nurse asked, tell me what it's like to take 5 medications, patients were far more likely to report non-adherence than they did if they just asked them, do you take all your medications? Okay. And then just remember the role of your pharmacist. When I give this talk to a lot of private practices, this is like remarkable stuff, but you guys already have the foresight to have pharmacists on staff. Pharmacists are amazing at caring for metabolic disease. We now have collaborative practice agreements in Kansas that allow pharmacists to have kind of wide discretion over changing medications. So once you're out of practice, consider forming collaborative practice agreements with your local pharmacists to say that they can do things like sync all the refills to 90 days and use combination pills whenever they're available, use generics whenever available, and even give them permission to titrate blood pressure medications if you trust them. Because this is a meta-analysis of 11 randomized trials with something like 11,000 patients, where they compared usual care from a physician to care with a physician-pharmacist dyad. And the physician-pharmacist dyad just crushes the physician on her own, right? In every way, from smoking cessation through blood pressure and cholesterol management. But I don't need to tell you guys that because you've already experienced it. Prescription synchronization increases adherence by about 5%, which doesn't sound like much, but it's huge. Combination pills, each combination pill you prescribe rather than an individual pill increases adherence by about 2%. Or the inverse is that every additional dose of anything that someone has to take in a given day decreases adherence by about 2%. So use all the combination pills that you can. And then finally, our staff can help us to overcome therapeutic inertia by triggering us to act on our high-risk patients, as you see there. So the thing that I always get when I say, if the patient's blood pressure is high and you know they're taking their medications, advance the therapy, is this. The pushback I always get is, I don't want to make the patient fall. So I want to set your mind at ease regarding this when it comes to blood pressures. This is the treatment algorithm from the appendix of the SPRINT study. If you can't read that, I'll go through it. It says, so remember, they saw people monthly, and they said, if at any point the patient's blood pressure is over 120, the appropriate step was to titrate or add therapy. 120. So you can argue over the goal, but they were being very aggressive with this. So anytime a single blood pressure was over 120, they advanced therapy. So you would think they saw a lot of falls, right, by making people orthostatic. They did not. They saw no increase in falls in this study by treating people's blood pressures to 120 instead of 140. And this has recently been backed up by a very high quality meta-analysis showing that intensive blood pressure therapy is probably associated with about a 7% reduction in orthostatic hypotension versus people treated less aggressively. Now, that's not to say that you guys couldn't go out and give somebody 100 milligrams of metoprolol today and make them fall down. Of course you could. But chronic blood pressure management with good adherence treated to a blood pressure of 130, there is no evidence that that makes anyone fall. All right. The way that Kaiser gets their blood pressure control to 90+% is this protocol, and you can get it right off their website. So they say that anyone with a blood pressure 140/90 gets an ACE inhibitor thiazide combination, and they only use one dose, right? They treat this like we ought to treat warfarin therapy, right? Where you should only ever prescribe one dose of warfarin. Patients can cut it or double it or whatever. But they do the same thing with lisinopril hydrochlorothiazide. They start with a half a pill of 20/25 and advance that. If it's someone with pregnancy potential, they eliminate the lisinopril. And if they're uncontrolled, then they add a calcium channel blocker, again, a 5 milligram amlodipine, half to begin with, then a whole pill, then a full pill. If they're uncontrolled on that, then they add spironolactone if their GFR is greater than 60 and their potassium's low. If not, they add bisoprolol. And that's it. They check labs once in a while to make sure no one's hyperkalemic, but they don't mentally masturbate over the problem and say this person also has, Raynaud's phenomenon, therefore they need a calcium channel blocker first or whatever. people just go into the protocol and they advance until they can't tolerate it anymore. And about 15% of patients get kicked out of the protocol because of electrolyte abnormalities or because of something else. But at the end of the day, they have blood pressure control that far exceeds almost any other health system in the country. And again, they have more patients dying of cancer than they have dying of heart disease.
Dr. Moore, how often are they checking labs? Are they, every time they titrate something, or how?
So they check labs within 2 weeks after changing their ACE or thiazide or spironolactone. For calcium channel blockers and beta blockers, they don't check labs at all. And so that 2 weeks is a compromise, right? Because we know that with like beta blockers and ACE inhibitors, you see an effect within 48 hours. We know that stuff like spironolactone takes forever, right? It takes an eternity to see a blood pressure difference with spironolactone, but they've compromised on 2 weeks as their recheck for everybody just to keep it consistent. And so back to our patient, should we recheck his lipids? He's on a moderate intensity statin now. And so it's real, this is flip-flopped a lot in the literature the last few years. And we've kind of landed on the side of don't recheck his lipids unless you think he may be extremely high risk or you think he may not be taking his medications. So we recheck his lipids for adherence, to check his adherence, and we recheck if he's extremely high risk, because if he's extremely high risk, we may add a PCSK9 inhibitor on top of a high intensity statin. What is very high risk? It's 2 of those major ASCVD events, acute coronary syndrome, MI, stroke, or symptomatic peripheral arterial disease, or it's 1 major ASCVD event plus 1 other high risk condition, as you see there, age, diabetes, etc. So we don't necessarily recheck his lipids unless something else is going on. We put him on an appropriate dose of a statin and monitor for adherence. So let's fast forward 10 years with our guy. He's now 66. He's gained about 10 pounds. He's now diabetic and well controlled on metformin. Triglycerides are about 200. And he's still on his appropriate statin. So what now? So remember, up until very recently, we had no therapy for triglycerides that made any difference in how long somebody lived. We could make their triglycerides better with niacin or with fibrates or lots of things, but it didn't make any difference. Nobody lived or died any sooner or later because of the therapy. We still use fibrates for people who are at risk of pancreatitis, but they've largely been supplanted by other therapies. So beyond diet and exercise, beyond making sure that his blood sugars are well controlled, beyond screening for hypothyroidism, alcohol abuse, and other things, the preferred therapy now for hypertriglyceridemia in patients at elevated risk is prescription eicosapentaenoic acid. Remember, EPA, remember fish oil is 2 things, eicosapentaenoic acid, and what's the other one? DHA, deoxyhexanoic acid, whatever DHA is. DHA does nothing, right? It does nothing. EPA is where all the therapeutic benefit comes from. So eicosapent and other prescription EPA agents are simply a highly purified eicosapentaenoic acid with no other contamination from the fish oil in them, and it's at a big dose, right? So 2 grams twice a day. And we know that agent or that group of agents will reduce the triglyceride level by about 1/4 and cut cardiovascular mortality by about 1/4. They just missed an all-cause mortality reduction in this trial. I mean, they barely missed it. The most commonly known trade name for all these is Vascepa. Unfortunately, it costs about $1 trillion a year, and it's just glorified fish oil. Okay, so outside the clinic, what resources can you offer? And I'll buzz through these really quickly. Don't forget about the chronic disease self-management program. Wichita State offers it for free. There are a couple of other places in town like Project Access that offer it as well. It's free everywhere. It's a lay-taught chronic disease management program. There's also a diabetes-specific one. There's also a chronic pain-specific one. It's 90 minutes a week for 6 weeks. It has a huge effect on blood pressures if you use it for that. If you're interested in getting patients into it, go to selfmanageks.org. Okay, it costs them nothing. But the last thing I want to leave you with is that if you want to look at this from a crassly commercial capitalistic way, the reason you should transition your practice toward team-based care is because you'll make more money if you do it. You will hire more MAs, but you will make more money at the end of the day. So we know that the median payment package for a Sedgwick County MA is just short of $50,000. That's benefits plus salary, right? We know that a 99214, that's a couple of years old, it reimburses about 110 bucks now, right? So about 110 bucks for a 99214. So to pay for 2 additional MAs, you need to see 4 additional level 4 patients per day. About 2/3 of your Medicare patients are already level 4 patients before they ever come in the door. And we know that people that see patients under this model increase their number of patients by about 13%, increase their RVUs by 11%, and see a net return on investment. That's money that they're taking home at the end of the day of about $400 per day. You make an additional $400 a day by hiring 2 additional MAs and following this strategy. In addition to the money that you make, you will not go crazy, right? You will not end up like me, burned out of clinical medicine, working for the CDC instead. Not that I have a bad life, it's pretty good. But it's not what I was trained to do originally, right? So if you practice under this model, you're 3 times more likely to have all your notes done by the end of the next day. That's not because the documentation burden goes down, it's just because other people are doing it for you, right? You invert the traditional model of 1 hour spent with patients for every 2 hours that you spend with a computer. That it inverts to 75% of your time spent with patients and less than 25% of your time spent with the computer. And we know that patients don't mind having a scribe in the room. In studies, about 2/3 of patients say that it was actually nice to have a patient in the room. Most of the others say they don't care either way, and about 2% say they didn't like it. They tend to be a vocal 2%, but they're there. And physician burnout rates in this model fall by about 80%. And it saves the system money, not by taking care out of your clinic, but by putting more care into your clinic. Okay, so this is a system that is designed to help primary care doctors succeed, which is not something you can say about many things in American medicine. So I will challenge you guys that, like today, you could go to your pharmacist and say, which of these things do you guys not feel empowered to do right now? Switching to generic medicines, syncing prescriptions for 90-day refills, using combination pills, whatever. Then you guys can work on a clinic workflow that sends all of your suboptimally controlled hypertensive or dyslipidemic patients to the chronic disease self-management program. You can give all your patients a list of places they can get their blood pressure checked and a way to send those numbers back to you. They can write them on a grocery bag for all I care, but you can use things like your portal or special palm cards or whatever. Over the next year, you could work on getting manual blood pressures replaced with automated blood pressures in your clinic, and you can empower your MA staff to do more than they're doing now. And if that means hiring a few additional MAs, I hope I've given you the financial case to make that happen. So those are my conclusions. Hypertension and dyslipidemia control are the single most effective interventions we have in terms of making people live longer. The reasons people don't get optimally treated, half of it's your fault in terms of therapeutic inertia, although it's not really your fault, right? The system's set up to promote therapeutic inertia. Half of it's the patient's fault in terms of suboptimal adherence. But again, it's not all the patient's fault. Drugs are expensive. It's hard to get to the pharmacy, whatever. And we have community resources that help. Dividing all these duties up not only makes your life better, but makes you more money. The end. What questions does anyone have? Hope I came in under time. I can't see a clock anywhere.
Yeah, this is so much a question as a comment, like with the kind of the barriers, the first thing I think of is this distrust in the number. Like our clinics are used to this, like we measure blood pressure of people, you know, with their legs dangling off the bed, their back not supported. I mean, it's all of these kind of things that it's hard to put trust in that number. I think that definitely plays into why we don't prescribe more aggressively, or at least why I don't.
Yeah, no, I mean,
Challenging thing.
I think looking at technique is a totally reasonable thing to do. Yeah. If you look at the AHA ACC guideline on getting an accurate blood pressure, I mean, it's like a 10-page document. It's a huge document. And so people tend not to do it correctly. Automated cuffs take some of that away, not all of it. They can still dangle the legs. The patient can still be talking during the measurement, stuff like that, but it helps a lot.
Good question. Is there a way for our patients to get transport to the kind of disease management programs? Because that is people out there for a lot of our patients. And two, you said that the purified fish oil is $4,000 a year.
Yeah.
So do they just take 10 fish oil tabs a day to the equivalent, or how do I make this happen for my patient?
Yeah, no, good question. So one is how do you get patients to the CDSMP program, and one is about how do you get patients a dose of fish oil that actually makes them live longer. In terms of Wichita State's program, they actually have classes at the Community Engagement Institute, which is in Old Town, which may be easier for some of your patients to get to. The second question on fish oil, yeah. So the trouble with a lot of fish oil, there are some prescription forms out there like Lovesa. A lot of fish oil is just kind of garbage, right? It contains vegetable oil and has like other pieces of fish in it. I mean, it's just awful. The prescription forms, I've never seen a study that said it takes this many Lovesa pills to match this dose of Vascepa. I don't know if such a study exists. It's a good idea. So yeah, we're stuck with it right now. It's an expensive drug.
That prescription plans won't cover this.
Say that again. Sorry.
Generally, you said that prescription plans won't cover this.
Oh no, for high risk, for patients who qualify for therapy. So if you have an elevated ASCVD risk and your triglycerides are over 150, they should cover it. It may just be a tier 3 copay, right? So they'll pay, who knows, $40 a month for the copay or something. Yeah. Because again, I mean, you're talking about a 30% or 25% reduction in cardiovascular mortality with the drug versus without it.
Hey, Dr. Moore, what are your input as it relates to standing blood pressure for those over age 65?
Yeah, so I think that was Dr. Duggins. That's a good question. Should we be checking standing blood pressures in people over the age of 65? As far as I know, the ACC/AHA recommends against it. Their blood pressure protocol says everyone should have their blood pressure checked exactly the same way. And again, we have, I guess there's always the risk of autonomic insufficiency, but if you take the trial data, we're not increasing fall risk by treating people's blood pressures. Now, it could be that someone skips their medication for 4 days and decides to take it all or something like that, but the data is not supportive of increased orthostatic hypotension risk with intensive management. All right, thanks for coming.
Should I? Either whatever you guys want. I have to pull it up. So.
Should I hit stop presenting or?
Do we hit stop presenting or do we just?
Yeah, I got it.
Okay.
Oh, she's good. Great. Thanks for the water.